الآن
نعم.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين. اليوم يعني محاضرة يعني قيمة بيؤديها الدكتور القدير كبير أطباء صالح بن سلمان في مجال التروماتيك هيد انجري. إن شاء الله نستفيد من هذه المحاضرة. وطبعا أنا الآن تكلمت باللغة العربية، ولا كان يفترض بأننا أعمل الانترودكشن in English, but Dr. Salman is well speaker. I think he is one of the international speaker that can convince all audience about about his lecture. Please.
Thank you. السلام عليكم ورحمة الله وبركاته. حياكم الله جميعا أيها الأخوة الأفاضل. Thank you very much for your introduction. I'm a very bad English speaker. I will try my best to introduce myself and to introduce this very important subject for all medical workers and medical practitioners. Traumatic brain injury is one of the challenging subjects which meet every one of us, not depending on the specialty, which specialty do we have. That's why you will see how I try to repeat every time. This type of subjects should be understood from every specialty, not only the neurosurgeons. It's a very big mistake, especially also in European countries and America, trying to put the traumatic brain injury only for the neurologist and neurosurgeon to treat these cases. But in the developing countries and other countries, these patients not be able to meet the neurosurgeon or neurological surgeons in many circumstances. That's why I am insisting to repeat, please, every specialist should know how to deal with these cases. Yes, definitions is clearly for everyone. Traumatic brain injury means an insult happened for the skull and for the brain associated with or without bleeding. The clinical picture of these patients could be changed every moment, every second. Sometimes that may take days, as we will see. I will see in the following. The etiology, of course, we have three main etiologies. Would always discuss about the brain injury. Could be ranging from very light injury, some headache, some pain, some bruise of the skin outside the face, and could be developed to persistent vegetative state, which make the patient or this person not be able to be a productive person in the community. In America, we speak about 50% of the severe traumatic brain injuries, according to because of the car accidents, 20% of fights. In Europe, the percentage is not that much differ. Some classification, including also the child abuse. I was in the last few years very busy with looking to war-related traumatic brain injury. Unfortunately, most of the studies and reviews just written for the soldiers and the military personnel, but not for the civilians who get injured. And this is a sign for us, for the people who are interested in research and statistics, to start collecting data, especially in Yemen, in Palestine, in Libya, in Iraq, in Sudan, to collecting data. What are the type of the brain injury which be resulted during these wars? And does these injuries related or changed according to the type of the weapons, to the type of the missiles, to the type where are they living, according to the environment, to the crowded of the population in this area. These many data, many informations must be collected in the next few years. Maybe we will meet a lot of problem with the politics to collect these data, but we have to. One of the things which sometimes deliberately would be ignored, which is the injury because of the brain, traumatic brain injury, but it's called post-traumatic stress syndrome. The people after the war, they get not only physical injuries, they got also a psychological injuries, which called the post-traumatic stress syndrome, which must be also included in what we called traumatic brain injury. Mostly with anxiety, depression, sleep issues, irritability, concentration problems, fatigue. These problems lead patients in many cases to do the suicide. What is the difference between the PTSD and TBI? Of course, PTSD developed after extreme stress, combat, or life-threatening events. Brain function changes, making it harder to process emotion. Fear, memory, and decision-making center must be affected. These patients to decide always, all the time, the wrong decision, which will be remarked from the relatives, the people who are living with them at home. This patient is totally different. It's changed, it's altered. TBI, physical injury of the brain because of the explosion, burst, or direct damage of the brain. Memory problems and concentration issue, irritability, and sleep disturbances overlap in both conditions. You will get often many patients with these problems, but you can't order if these problem because of the PTSD or TBI, or both of them. This table, I found it in the previous book that I showed you, would try to differentiate PTSD patient and TBI patients, how to differentiate between them, but the actual school trying to merge them together to put them as a new classifying, understanding the pathophysiology of the TBI patient with PSD. Always keep in mind, it's very important, who are working in the emergency center. Those patients who are coming to our emergency in coma state after brain injury, does this loss of consciousness happen before they fall down, or did they fall down and then they lost their consciousness or altered their consciousness? Extremely important to understand the history. How did this problem happen? To put the correct diagnosis or correct differential diagnosis, which will have a consequences to the type of the investigations which be done, as I will speak later. مش عارف ايه هنحط لي خط هنا او okay, no problem. The box, I will say the box classifying the head injury to 4 main classifications, which is nowadays should be renominate: closed head injury, which is non-penetrating head injury; open head injury; acceleration head injury; and deceleration head injury, which are related to the traffic accidents and war accidents. Home accidents are extremely important to be understand what has happened. Child abuse, we have to take in consideration with the children who came to the emergency department with traumatic brain injury. We have to look after other signs of the child abuse. These definitions are very important to be understood before we go deep in the TBI. Concussion is a transient altered consciousness as a result of the closed injury with the elderly people or young people. They slip down or they get a punch on the head or any type of injury get to the head, and the patient have an alter of consciousness, not necessary to be in coma, just only a few seconds of alter of consciousness. Cerebral contusion, which is a high density injury to be seen in the CT scan, most probably because of the hemorrhagic contusion of the cerebral cortex. Contact injury, which is the injury to see on the other side where the actual physical injury or trauma happened. Diffuse axonal injury, which is one of the most difficult injury to be diagnosed and to be found. It's diffuse axonal injury of the cerebrum and the midbrain because of the injury, and you wouldn't be able immediately or in a while time to find these injuries unless if you have a tractogram MRI, which is very, very high sophisticated diagnosis and take a long time to find out the diffuse axonal injury. These patients come normally with a very serious neurological situation. يا أخي صخر، في أحد بيعمل رسمات على الشاشة مش عارف هو عن طريقك ولا عن طريق أحد بيشوش علي.
ما
في أحد يقدر يمسحها هذه، تقدر تمسحها الرسمات هذه؟
مش عارف أنا مش عارف من الذي بيقدر يتحرك الآن حقيقة.
الآن ما في بس في واحد بيرسم أخضر وأزرق وأحمر بيشوش بعض الشيء. إذا في إمكانية تمسحها امسحها.
بنحاول نمسحها، نتواصل بنحاول نمسحها إن شاء الله.
شكرا. Of course, the most important type of the clinical classification for these patients is the Glasgow Coma Scale. It is universal, must be known from every physician who have a responsibility to work in the emergency room or with the ambulance or with the supportive support outside to collect the victim from the injury area. Okay. Of course, UCS I said is very important and should be in this way. Opening the eye spontaneously, directly when the patient talks to the doctor or the nurse or the one who trying to help him is 4. Only on voice, if you call him, and otherwise he closing the eye, we are in 3. Pain, opening the eye only under pain stimulation is 2. If the patient not able to open the eye is 1. Verbal response is that the patient oriented, able to answer and to say her name, her birth date, what is the day today, where he was, what happened. We speak about 5. Confused, the patient able to answer and to communicate, but not really clear in it, not able to understand what happened to him, what was happened during the trauma. Inappropriate words, the patient speak, but we can't understand him. This is 3. And incomprehensive sounds that just like no, we can't order them as words. There are 2. The patient never able to talk. We speak about 1. The best motor response, according to our ask for the patient, if the patient fully recommends, moving hands and legs, 6. Localizing the pain is 5. Withdrawal from the pain is 4. Abnormal flexion here 3. Abnormal extension, which is a bad prognosis sign, is 2. None, also a bad prognosis sign, is 1. Please consider always, all the time, when you see the patient, be sure that the patient doesn't need any help before, such as hearing hearing machine or hearing over ear, glasses, patient able to understand your language at all. The patient before wasn't mental issues have. These things also very important to be take in consideration to understand why we got a bad Glasgow Coma scale, because of other issues or because of the traumatic brain injury. Because always we have to go from the bad situation to improve the bad situation, or to prove the patient have another issue to see that bad. As I said, grading head injury according to the Glasgow Coma scale, the patient is scaling by 15. It is low without loss of consciousness and no amnesia. If the patient from 14 to 15, we have to speak about mild head injury, but got a loss of consciousness less than 5 minutes, or impaired memory, can't understand what or remember what happened with them. Moderate from 9 to 13, or we have 15, but the patient lost the consciousness more than 5 minutes, or have a problem with the with amnesia, not able to remember what happened. Severe, of course, from 5 to 8 on the Glasgow Coma scale. Critical 3 to 4. Okay. What is concussion? As I told you before, the concussion is the alter of consciousness of the patient after the injury. Maybe loss of consciousness or just altering of the consciousness. Sometimes we see vomiting, balance problem, inappropriate crying of the child, glazed look of the eyes. What does it mean? Meaning the pupil of the eye looks always upward, forgotten an assignment of the play, an inappropriate laugh, the child inappropriate laugh, and delayed response of the question. You ask a normal, simple answered question from the child tries to delay this answer. Confusion about the location of date, game score, and so on, or amnesia. In this case, you have to check the patient by your eyes and your hands and be really anxious. It could be here a big problem for this child. Physical symptoms, you have to see any bruising, any blue injuries. If the patient have cranial nerve injuries, if the patient have bone injuries, the emotional symptoms are very important to see. The child is depressive, panic attack, has a panic attack, or anxiety from everyone around him, or panic attack from the specific person in the examination room. This leads us to one of the most important cause of concussion by the children, which is the child abuse, which is not few. To understand the traumatic brain injury and to localize where is the injury, we have to understand the anatomy, the external anatomy of the skull, how the face looks like, how the symmetry of the face looks like, how the mandible looks like. These are very important anatomical landmarks to be tested, to be seen during the physical examination. The skull base, the internal skull, how it looks, including also the C1 and C2 cervical vertebrae are the part of the skull examination. Children below the 2 years, we have the frontal fontanelle and the dorsal fontanelle, and pretty important area to be tested by palpation or sometimes with ultrasound to find out if they are bulging or depressed below the normal level. Of course, the cross-section, this cross-section is extremely important to be understand the different type of the traumatic brain cerebral, traumatic intracerebral hemorrhage, which is, we have the skull, we have the periost, we have the skull itself, and then we have the womb between the skull and the dura mater, which is called the epidural womb. And then we have the dura. Below the dura mater, we have what's so-called subdural room, which we are looking for the subdural bleeding or hematoma. And we have the arachnoidal area where we find the subarachnoidal bleeding or hemorrhage. Of course, in the epidural room, we will see a bleeding, arterial mostly, from the middle meningeal artery because of the fracture of the skull. This bleeding is always acute, always very hard, always causing what called epidural hematoma, and must be surgically treated. Subdural hematoma mostly because of the disruption of the bridging vein between the superior sagittal sinus and the brain itself, mostly to be seen by elderly people in a chronic form and the young people in acute form. And the subarachnoidal hemorrhage, we have two main causes. We will come to them. I will speak about them in detail. Maybe because of the laceration or deceleration of the brain cortex itself, and is accompanied with the intracerebral bleeding and subarachnoidal hemorrhage, or it is alone subarachnoidal hemorrhage would lead us to another differential diagnosis. Brain injury from the trauma results from distinct causes impact damage of the brain, which called primary brain injury because of the broken bone or direct injury of the bone, laceration and deceleration of the brain stem, contusion also, and the secondary injury because of the other injury of the brain, which goes to the secondary injury of the brain, which lead to an elevation of the intracranial pressure. I will come to all of them. Okay, traumatic intracranial hemorrhage. We have the epidural hemorrhage or bleeding, arterial, mainly from the middle meningeal artery associated with skull fracture. Traumatic subdural hematoma, we have an acute form and chronic form, somebody called, or a third form, which is subacute. It is venous bleeding in a subdural space, as we spoke before, most common cause of delayed deterioration of the death. And this diagram, I love it because it's trying to clarify the problem without any mistakes, trying to. As we said, skull fracture associated with the arterial lesion, arterial laceration of the middle meningeal artery, and cause the epidural hematoma, which the patient coming mostly with deterioration of the consciousness or in coma. And we have the subphyseal herniation of the brain, should be treated immediately surgically. Subdural hematoma looks like a crescent, subdural space. It is because of the venous laceration because of this trauma. With young people, mostly acute, elderly people, chronic, maybe also acute also, but mostly chronic, and it be very slowly. We meet many cases, I will come to this later on, but we meet many cases. They came in the emergency room after a very strong trauma, falling down from stairs, falling down from balcony, traffic head injury, and they come walking in the emergency room. You do the CT scan, you see nothing. He's young, you send him home. They found him at home, died, because the subdural hematoma happened in hours. The pathophysiology of this problem is clear. They got this bleeding very slowly, and with the time, the patient come to you in the emergency room on the foot. He is still under adrenaline after the trauma, still able to do everything, talk to you, very convenient. And he go home or she go home, start to get tired and headache. They go to the bed, tired and headache, because the starting of the bleeding to irritate the meninges. And the elevation of the pressure in the brain, they get tired and they sleep. And during the sleep, this pressure gets high and high and high, and they get died. Cortical hematoma due to the cortical injury, direct or indirect, as we spoke before, should be treated surgery. It is a controversial discussion about this problem. And this is another schema, speak about the three type of the traumatic brain hematoma. Now, we will speak about the main traumatic brain injury, which is the traumatic subarachnoidal hemorrhage. In the CT scan, you will see a hyperdense in the sulci in this area, all in these areas, in unilateral. The other side would be
دكتور الصوت مش واضح. الصوت مش واضح.
اوكي، كيف الان احسن؟ ابغى اتاكد.
الصوت عندنا واضح، يمكن يعتمد على المكان الذي بيسمع المحاضرة فيه أو ما بتكون قريبة.
في ألمانيا صحيح واضح، بس
انت صوتك واضح، انت صوتك الان واضح. الدكتور الحاضر الصوت مش واضح.
اتابع؟
طيب تابع يا دكتور، يمكن إذا خليت الميكروفون هكذا قريب من
أنا أجرب وأشوف الآن.
يلا شكرا.
Traumatic subarachnoidal hemorrhage, as we saw now, this picture shown a CT scan with subarachnoidal hemorrhage, and we have to understand now why we say this is subarachnoidal hemorrhage, because the blood, the hyperdensity in the sulci, we can compare with the other side. This is the normal sulci, which is full of the CSF, but here full with the blood. This is another case with the same problem. In the right side and the left side, we see nothing. Very important, if the history not clear, the patient get injured and the patient not able to determine that he lost the consciousness and then he fall down, or he fall down and then he lost the consciousness, we have to go after CT scan to the conventional angiography. Why? Subarachnoidal hemorrhage is one of the differential diagnoses of the cerebral aneurysm, and this must be ruled out if we are not really sure how the neurological deficit with this patient happened. Normally, if that is a traumatic subarachnoidal hemorrhage, the patient come to the emergency room if he is still awake and say, I got a pain in my head, like a bomb exploded in my head. Or he get the pain on the head after lifting something very heavy, or during sleep. Otherwise, the patient slipped down from the stairs or in the bed during douching, and fall down and they got subarachnoidal hemorrhage. If you are not sure, the patient not sure, you will not lose anything to exclude cerebral aneurysm. If you got like this picture, even if the patient say, I fall down, never hesitate to make an angiography, because the blood is accumulating in the circle of Willis area. We are seeing here blood in the arteria basilaris, arteria vertebralis area, arteria cerebra media, arteria cerebra anterior, arteria cerebra posterior, in all areas of the circle of Willis collecting the blood. We have to exclude aneurysm. This is the conventional angiography, pan-cerebral conventional angiography. How we are able to see the different arteries. It's very nice picture to study every single artery alone. You can get the catheter to the internal carotid artery to see the optical artery, to see the middle cerebral artery, anterior cerebral artery, posterior cerebral artery, and so on, to differentiate where is the problem, where is the aneurysm, if there is an aneurysm, or to exclude all that things. Alternative for the angiography, if it's not possible, you don't have a neuroradiologist in your clinic, you go, of course, to the CT angiography, which is good, sensitive method, but not perfect. Could able to show where is the problem. This is the patient of the stroke. If the arteria cerebra media in the lateral third, we can good find the problem of the stroke or occlusion of the small arteries, but really with aneurysm, small aneurysm, it's difficult sometimes to find it. Or if the patient very young and the bleeding is too much, it could able to push or press on the aneurysm to flatten it and not be able to see. But on the conventional pan-cerebral angiography, is better to see this problem. Of course, the magnetic resonance angiography is something modern, something very nice, but it takes very long time. And in such acute cases, you will not be able to wait until the magnetic resonance angiography, which take about 15 to 20 minutes. Here you have in seconds to have the results. Of course, here you need an experienced neuroradiologist or the neurosurgeon who are able to do the angiography. And this picture, I love it because we have a comparison between the normal CT scan, conventional CT scan with the angiography, and the conventional angiography with the spasm of the arteria cerebra posterior. Of course, we'll go quieter. Okay. Another problem we are facing several times in the emergency room, which is diffuse traumatic cerebral edema. We got patient with coma, increased pressure in the brain. The patient come in coma, of course, vomiting, pupils are very wide, and you make a CT scan and you see structureless brain, which is homogeneous, no sulci, no ventricle to be seen, or barely something to see, which speak for an diffused traumatic cerebral edema, which of course we have to intervene surgically to open and to do the decompressive craniectomy to remove the skull from this area and from this area to reduce the pressure in the brain. In some cases, like sometimes like this in a trauma, or here like a malignant arteria cerebral media infarction, you have to also to do a decompressive craniectomy, which I will come to the technique further. As we see, as we said before, the clinical assessment is very important to deal with the case correctly. Pre-hospital should be describe the mechanism of the trauma, follow the GCS in the ambulance before the patient arrives to the emergency room. Management of the ABC trauma algorithm is very important. ER or hospital period, patient should be reassessed again from the emergency doctor, from the neurosurgical doctor, and re-evaluate ABC if it is important to be happened. What we have to see, what we are looking at. First impression. First impression is extremely important. Skull wound, where are they? How deep are they? Fracture of the faces, asymmetry of the faces, swelling, bursting, Racon sign, which is a sign of the skull base injury, discharge from the nose or from the ear, which are the signs of the skull base injury, stiff neck, stiff of the neck because bleeding or because of the injury of the cervical spine. Primary management, as we always say, always learned, classical medicine is the best medicine. A, B, C. Airway should be protected and open. Patient must be breathed. And the last thing is the circulation, pulse, blood pressure control. And then you have to deal with the bleeding if there are external bleeding or any other injuries. Neurological examination, we have to look for level of consciousness, cranial nerve, motor examination, sensory examination, neurological reflexes, if there are time for all of them. As we said before, the level of consciousness, the Glasgow Coma Scale is the golden standard worldwide, universally to deal with. Not depending on the way of speaking language, the area you can describe the patient in this Glasgow Coma Scale in your very simple language, the other doctor will understand you and start to deal with it. General inspection is something very important to be deal with. Of course, we have to see how the patient like, where he found, if there are other victims in the area. Speech abnormality, are we really sure the patient have another glossopharyngeal injury, vagus injury, or the patient speak other language? Maybe the patient speak not our language. Facial asymmetry, if the patient have a facial asymmetry because of facial palsy, or because of the fracture of the mandible, fracture of the zygoma, eyelid abnormality, the patient chooses before the injury or after the injury, pupillary abnormality, if the patient prior the injury having a surgery in the eye, which causes the pupil to be white. Strabismus, limbs. Does the patient have limbs? Sometimes we got the patient with the ambulance and start the ambulance doctor to say, yeah, he can move all limbs, and you check the legs, you find the patient have an amputation on the left to the right legs, which is really common. It's really bad sign for the doctor who associated the rescue of this patient. We have to check with the patient, see them with eye and hold them with hands. We have to see and to be sure the patient need a hearing aids, visual aids, having a prescription to take some medications maybe lead to the alter of consciousness, not because of the trauma, but maybe because of the medication that he take or drug abuse or alcohol abuse. Radiological examination, we have X-ray of the skull. It's not anymore a standard and not recommended to be done anymore. Ultrasound, it's one of the very nice methods to be done with the children below the 2 years to throughout the anterior and posterior frontal to see the bleeding in the brain, to avoid the CT scan if the patient in a Glasgow Coma Scale 13 to 15, we start with ultrasound and start to follow up the patient inpatient. CT scan and angiography, as we said before, if we have any doubt that the patient have an subarachnoidal hemorrhage because of aneurysm, even if this doubt less than 1%, please do the angiography and rescue your patient. MRI, if you have time, if you have the equipment, do it, but mostly you wouldn't need it. As we said, pathophysiology, subdural hematoma because of the venous bleeding, epidural hematoma because of the arterial bleeding. This is how the epidural hematoma could be seen, and the subdural hematoma, the above picture is acute and a chronic subdural hematoma of the elderly patient. Get a trauma for 2-3 weeks under the platelet aggregation tablets, and come to the emergency room or to the neurosurgery praxis, complaining of headache, maybe a little bit paralysis of the right side. You made the CT scan and you see hypodense fluid accumulating in the subdural realm. And below one, the second one is the patient with acute subdural hematoma because of the trauma. You see the subgaleal hematoma also. This must be, both of them must be surgically treated. This could be electively treated, and this must be immediate treatment with the decompressive craniectomy, and here with mini borehole trepanation and drainage. Patient with a cerebral hemorrhage, according maybe of the trauma, maybe of the hypertensive crisis, just like these cases, there are different schools. One school say should be treated surgically. Other schools say no, we shouldn't have. Both of them are correct. Both of them have very nice reviews. Could be seen in PubMed. As we say, traumatic subaqueous hemorrhage is our lovely subject to be talked always about. The right picture is a picture which is highly suspected of subaqueous hemorrhage because of aneurysm. The other picture, the left picture, is not really indicate that aneurysm below it, but it's not excluded. You have always to be self-critic. Self-critic means that you got the picture. Maybe you have very experienced eye, but still be able to criticize yourself to say maybe that aneurysm. Still, we have to do the angiography if the history of the present illness not clear for you. I love this scheme. I distributed it for whole doctors that I knew them, how to understand the CT scan, especially in the ER, how to differentiate blood, acute blood, which looks really white, hypertense, subdural and epidural hematoma, how they looks like, how to differentiate the subarachnoidal hemorrhage. What should I wait because of the increasing of the intracranial pressure in the subphalangeal or infratentorial herniation? How may I diagnose them? And the last row show me the stroke, how they looks like. Surgical treatment. Surgical treatment. Try all you can before surgery to stabilize the patient and treat the shock. Extremely important. Try to treat the shock before you get the patient in the OR. Decompressive craniectomy means the patient will lose a lot of blood during the surgery. And if you get the patient with the low blood pressure, with the many hemorrhagic shock, or the hypervolemic shock, or cardiogenic shock, he will die on the OR table. First of all, we have to have a good relation with our anesthesia doctor, ICU doctor, to stabilize our patient before we get them in the OR room. And then we have to decide decompressive craniectomy with or without durotomy, to open the dura or not to open the dura, insertion of a drain alone, insertion of the subdural drain or external ventricular drain, or exoperative borehole, which is not a choice anymore in these days. Positioning of the patient is extremely important. When you localize where the pathology, you have to decide to do the frontal craniectomy, fronto-parieto temporal craniectomy, or fronto-temporal craniectomy. You have to fix the patient in the Mayfield clamp or the posterior craniectomy, which is a method of choice for the posterior intracerebral hemorrhage. Important that easy approach for you as a surgeon to the pathology. One, consider always the jugular pain are open and not kicked or knicked. Pins shouldn't be on the way of your skin incision. Always draw the craniectomy before you draw the trauma flap. Before you draw the whole incision, draw on the skin of the patient where is the craniectomy should be done. And then you can remove the hair from there and draw the skin incision. Trauma flap is like that. We have to take about 1 to 1.5 centimeter away from trigger to avoid fascial nerve injury. And this question mark, very common, how skin incision for the trauma flap. This looks like you open the skin. Always prepare the periost separately from the skin to have a very good flap for your dura if the dura injured during the craniectomy. And then the temporal muscle should be prepared separately, and a borehole, and then you do the craniectomy, and after where you do the duratomy. Many schools, some open it in crossway, some in a five-star way, some in triangle way. All methods are correct. Most important to be taken consideration, not to snore or press the edges of the brain during opening the dura. During the surgery, of course, we have to talk and communicate with our anesthesia to give the patient all the time hyperosmotic fluid to take the edema away from our way. Hyperventilation also helping these patients very well. These instruments, which should be or must be on our operation table, we have the borehole, we have the cranietome, we have the clips, of course, skin, and the dissector to remove the dura from the margin of the boreholes, and the elevatorium and respiratorium. This order, which is I really like, if you are a right-handed surgeon, should be the assisting nurse on your right side and your surgical assistant on the left side. If you're left-handed surgeon, the otherwise. Always take this in consideration. This is a bifrontal craniectomy case done in our clinic. I did this with Dr. Hamid. If Dr. Hamid here today, we did the bifrontal skin flap, and the periost is separately removed. And we see here this is the frontal bone, and I made 2 boreholes on each side of the superior sagittal sinus. Superior sagittal sinus, if it opened during the surgery, that wouldn't be a nice day for us or for the patient. That's why do 2 boreholes on each side, and then prepare the dura and the superior sagittal sinus from the bone, and then open the bone with the cranietome in both sides until the skull base. This patient of the frontobasal glioma, the bone graft go to fluid with gentamicin and vancomycin. And then we do what's called Lindemann holes in the skull and in the skull graft that I removed. After the surgery, this will be back and get connected to the skull of the patient. Mini borehole trepanation is a treatment choice for the chronic or subacute subdural hematoma, but for cooperative patient, suitable surgical environment, experienced surgeon and nurse, good follow-up. The patient should be stay in the hospital at least for 1 week. The drain stay in the subdural room for 5 days, and immediate CT scan after the surgery. Antibiotics still a controversy subject, should be given or should not be given. I give anyway antibiotics for the patient before the surgery and after removal of the drain. As I said, it is choice. It's the golden standard. You don't need a lot of equipment for this method. Just you need a cooperative patient, cooperative surgeon, cooperative cooperative and experienced nurse. After you check the CT scan and check the subdural hematoma where it's localized, you choose the area where you have to bore. You have to make a local anesthesia and then incision with the 11th knife, and then the 3.1 millimeter bore, start to boring a hole through the skull from tabula externa, through the spongiosa, and then to the tabula interna. And after that, you insert your subdural drain. This is from Spiegelberg. Have a very nice, it's really, really very nice recommended because it lined from outside and from inside with gentamicin as an anti-infection drain. We insert it through the hole until I reach the subdural room, and I hold the membrane outside, and I leave the drain go smoothly in the subdural room, and then start to connect it to the head and to connect to the draining area and connect to the drainage. Of course, it should be fixed at the head, and the drain bottle would be on the side of the patient, never under the head pillow or hanging on the bed. So it should be on the heart level of the patient, like this. This the instruments, very simple, goes very quickly. You don't have to go or to annoy or anesthetist with this method, unless the patient get worse during the surgery. I made a video for you just to see. The patient is very cooperative. Start talking with the patient. And during the surgery, we ask the patient to move his hand, move his legs, to be sure that everything is fine. Yeah. And just inform the patient that we'll start to have a machine on the head, and always ask the patient if he's going well. And always ask the patient, of course, pointing, lateral, and dorsal. And this feeling, how you go through the tabula externa and spongiole and tabula media, it comes with time. That's why I said experienced neurosurgeon or experienced surgeon. I'm still insisting this method should be learned from everyone because it's really a life-saving method. Before you reach to the tabula interna, you feel a lot of cracks around the boreholing. And here you see the patient. Always communication with the patient is extremely important. Yes. Now you see how the subdural bleeding comes out. Always try to be hurried to insert the drain in the subdural room to avoid rapid loss of blood. To avoid rapid loss of the blood, to avoid subdural hematoma on the other side. And after you find the hole, hold the membrane and just push the drain in the subdural hematoma. And then you are start to, sorry. This is subdural hematoma, where the brain sitting. Bring home message for you. GCS and clinical assessment is the clue to success our work. Be always ready to help. Traumatic brain injury is a situation does not tolerate hesitation. That's why be always ready and up to date how to deal with the cases. Ask always correct questions. Every injured victim deserves a chance to be helped. Never give old age an excuse to provide help. At immediate arrival, never ask if there are a testament not to help this patient. And this is the dialogue which in all emergency room to use with a traumatic brain injury. These are the different pictures we are able to see. شكرا لحسن انصاتكم. السلام عليكم ورحمة الله وبركاته. تفضل دكتور سامر.
شكرا جزيلا دكتور، يعني محاضرة يعني رائعة جدا، ويعني أكيد استفدنا منها كأطباء يعني من مختلف التخصصات. لكن الآن نبدأ بالسؤال الأول. نبدأ من الشمال مع الدكتور عبد الرزاق الصومالي. تفضل
دكتورنا العزيز، شكرا جزيلا على هذه المحاضرة القيمة ومفيدة. سؤالي هو a little bit tricky على ما يقال، يعني how do you differentiate between the two events, whether it is traumatic or non-traumatic? This is a critical and I mean it's a cornerstone of your management. What criteria and approach you will use? History, but sometimes patient came with he's confused. He is unable to give you any history.
Yes.
So what's your approach? That's number one.
Yeah.
Question number two, regarding the blood pressure management, do you use aggressive approach or conservative approach for blood pressure management during the first 6 hours? Thank you.
Thank you very much. First question, if the history not clear, I mentioned that before. If the history not clear, I will go with aneurysm. I will immediate. I have to exclude the rupture of the cerebral aneurysm. I will never lose anything. Yeah, this is the first question. The second question, I prefer, of course, according to the patient. I'm always referring this question to our anesthetist, but I prefer to go with the conservative management with the blood pressure.
Thank you very much.
You're welcome.
السؤال الثاني على البلد بريشر مانجمنت، is it aggressive or not aggressive or conservative?
I go preferably with the conservative management, but always I am referring myself to our anesthetists, how they should deal with the case according to the previous history of the patient, we don't know. I don't want to interfere with the problem if the patient previously have a problem with the blood pressure. But I prefer conservative.
I am stroke consultant, and usually we have a target during the first 6 hours. After 6 hours, we will be a little bit conservative. Do you have any target of blood pressure in this situation and in the traumatic one?
In the traumatic cases or in subarachnoid hemorrhage, my target blood pressure target, MAD, mean arterial blood pressure shouldn't exceed 80 mmHg, and the systolic shouldn't exceed 150 mmHg. This is my aim as a neurosurgeon.
Thank you very much.
You're welcome.
Assalamu alaikum.
Wa alaikum assalam.
First of all, I want to, I'm glad to enter this lecture with Dr. Saleh. He's our colleague, he's our professor. And I will thank you for your informative, excellent presentation.
Thank you.
Dr. Saleh, my question is there, you know that the report now is entering on all these surgeries. What about his role in its role in the neurosurgery?
Which report you mean?
The
robotic surgery.
Yes.
In these cases, have no rule.
No rule.
In these cases, never. I will not allow a robot dealing with my patients.
I mean,
especially the traumatic brain injury. Never.
So, no, it has no role in the traumatic injuries.
No, traumatic brain injuries, no rule. I never heard any clinic anywhere in the world spoke about the treating intracerebral hemorrhage or leading or giving a drain or decompressive craniotomy with the robotic. I never heard about this.
Yeah. So this is very sensitive operations. Need a skilled surgeon, difficult to be done by the robot.
I think it's impossible for robotic to do this. I will not. As a patient, I will never allow the robot to operate my brain.
Yes. فخورين فيك دكتور صالح، فخورين فيك جميع الدفعة عندنا، ودكتور صالح هو زميل دفعة ومن أفضل الأطباء. بارك الله فيك وفي علمك يا دكتور.
شكرا لك.
Any another question?
Dr. Sakar, I have a comment.
Yes, please.
Thank you very much for this nice presentation and holistic approach. The new guidelines for traumatic brain injury concentrate on preventing secondary injury.
Yes.
And this prevention starts from the field, the rescuer, how to rescue the patient in the field, how to transport, when it reaches ER, how the ER doctors applied the traumatic, primary traumatic survey, EBC. When the patient is reached to the ICU, how to humanize the brain, how to prevent hypoxia, prevent acidosis, prevent hypoglycemia, prevent hyperglycemia, to be targeted glucose levels, how to be handle mechanical ventilations to reach the target CO2, because hypercapnia is vasodilatory effect.
Yes.
Hypocapnia is severely vasoconstriction. How to monitor ICB, and according to this ICB, how to get target blood pressure, because the brain perfusions, there is simple equation. Brain perfusions MAP minus ICB. If the ICB high, you need high blood pressure. If the ICB is within the target, you can handle this according to that. And usually your target ICB to will stand 20 and the target perfusion pressure more than 60. In recent era, there is, if you have good neuro ICU, there is better outcomes. And for sure, surgical intervention is part of treatment of some cases, not usually the all cases, and this is need proper holistic diagnosis or structural diagnosis based on this. والذي وضحها الدكتور في المحاضرة. This is just
شكرا لك. This field is very large, very large. To make a lecture about the traumatic brain injury management from the beginning to the end. Yeah, we will need at least 20 to 30 lectures. But thank you very much. Very important points. Question is where the skull flap stored after decompressive craniotomy. In my hospital, I try to store this skull flap under the skin of the patient. Other clinics, if they have a refrigerator with minus 81 degrees centigrade, they could store it in their refrigerator.
الدكتور صالح، السؤال الثاني الموجود في الشات بيقول do you use synthetic materials؟
السؤال الثاني
For example, titanium plates instead of the native bone flap, and in which situation?
I prefer to use the patient flap, bone flap to have. If it's not possible, I go with this, titanium. Not really preferred for us, especially with the young patients. I go with the synthetic flaps, which be able to use to be done or to be prepared in another factory or other companies after taking a 3D CT scan of the patients. If we have to keep the patient without skull flap for a while, then we have to send the patient first of all for 3 to 6 months until the patient gets stabilized, and send a 3D CT scan to these companies to make for us an exact measure skull flap for this patient. With titanium, I'm really not that much satisfied. But it's not wrong. It's not wrong. Many colleagues like to do it.
الدكتور في أيضا سؤال يعني في الشات موجود، ما ندري هل يعني يفيد تخصصك أو يعني يجب عليك السؤال الإجابة عنه أو لا. How does distribution or disruption of the blood-brain barrier affect the development of cerebral edema?
The cerebral edema happened because of the interruption of the communication between veins and arteries, and resulting to produce what cause shunt effect, and blood still transferred from the artery to vein, but the osmotic pressure gets changed in the brain and starting to absorb the fluid from the blood-brain barrier in the cerebral cortex. Many steps of this mechanism still not clear for us as neurological surgeons. That's why we are trying to deal with this problem, firstly with hyperventilation, then with buffer system, and then with the hyperosmotic saline to take care of the problem. Then with the surgery, as the colleague Ibrahim Foya spoke about. But the mechanism is not really that much clear for us.
دكتور صالح، السلام عليكم.
وعليكم السلام.
كيف ترى مستقبل الجراحات في جراحة المخ والأعصاب؟ ما تشوف انها ماشية ببطء؟ التقدم في جراحات المخ والاعصاب؟
والله بالعكس، انا اشوف انه جراحه المخ والاعصاب في كل يوم فيها تحديثات اكثر وتحديثات احدث. طبعا جراحه المخ والاعصاب الان اصبح كاسم كجنرال، الان تحتها كثير سب سبيشاليتي زي الفاسكولار نيوروسيرجري، زي الابيليبسي نيوروسيرجري، زي الانكولوجي نيوروسيرجري، زي السباين نيوروسيرجري، زي كل واحد من هذه التفرعات تحته تفرعات اخرى. حتى البيدياتريك نيوروسيرجري برضه في منه تفرعات كثيره. ارى انه ارى انه الموضوع في تطور كل يوم، نحن في تحديث اكثر واكثر.
التطور موجود دكتور، لكن هل التكنيك والادوات المستخدمه كانها بطيئه ما زي الجراحات الاخرى؟
في حرص شديد جدا مننا كجراحين مخ واعصاب ان احنا نتسرع في الذهاب الى استخدام ادوات اخرى. طبعا الروبوتيك نيوروسيرجري، انت ذكرت الروبوتيك نيوروسيرجري في البدايه. الروبوتيك سباين سيرجري بدات تشتغل الان في حالات محدده طبعا، وما بيشتغلوها كل النيوروسيرجن. في كثير من النيوروسيرجن refusing definitely using the robotic, but بعض الانفال سيرجن اللي بيعملوا سباين سيرجري بيستخدموها في اللمبر سباين، في الثراسيك سباين ستابلايزيشن. لكن التطور اللي حاصل انه مثلا طريقه الستابلايزيشن حقت الكرانيو سيرفيكال ستابلايزيشن تغيرت من 10 سنوات الان، وضع مختلف تماما. استخدام الكاثيترز كانت كاثيتر مختلفه، الان تطورت انواع المناشير اللي استخدمت تطورت كثير. استخدام الكوسه هذا شيء جديد اللي هو الالتراسونيك نايف، رائع جدا في استئصال الاورام واستئصال الاماكن اللي لها علاقه بالابيليبسي بدون اصابه او نعمل انجري للفيزلز اللي في البرين. بالعكس التطور موجود، ولكن التطور يمشي بخطى حريصه. انا احب استعيد دائما كلمه ميركل، ان احنا we are walking on the very thin ice on a very thin ice. كجراح مخ واعصاب نمشي على طبقه رقيقه من الجليد، انتبه تنكسر تحتك فتطيح اللي معك. فبالعكس انا ارى التطور موجود، ولكن يمشي بحرص شديد جدا. لو تلاحظ الموضوع في امريكا، لا، في امريكا الامور مختلفه. الامريكان منطلقين اسرع من الاوروبيين كثير. لها علاقه طبعا بالسياسه وانواع الفيزيشرهم وانواع التامينات اللي موجوده عندهم غير اللي موجوده في اوروبا، والمساءله في امريكا مختلفه عن المساءله في اوروبا، فقد يكون هذا سبب.
دكتور الغالي، معذرة سؤال إضافي.
تفضل.
Which blood pressure lowering agent are you using في ال TBI, traumatic brain injury? Do you follow any guidelines that's to use one agent rather than any, or
no,
it's open up to the option by clinician?
I leave this for the anesthesia doctor, for ICU doctor, to decide what is proper for the patient. The beginning, for maybe 15 years ago, I was loving using Lipizzole, but now it is out of the market, and there's many new agents, blood pressure lowering agents in the market, much better than Lipizzole. I leave this decision, of course, for the ICU doctors to decide what better for the patient.
Non-traumatic brain injury like stroke with hemorrhagic element, usually we use labetalol or GTN infusion, especially for the first 6 hours. Once the patient is able to take anything orally, then we can continue his anti-hypertensive medication orally, or using GTN patch or captopril sublingual. Thank you.
Is there any further question?
Sorry, for captopril sublingual, it increased mortality in traumatic brain injury and the stroke in general. And it was used for some hypertensive emergency, but now in new guidelines, even nifedipine sublingual or captopril sublingual is increased mortality. Regarding anti-hypertension medications, we try to avoid the nitroglycerin and because it causes increase the ICB. Other infusions, we can use labetalol, nicardipine, The issue with nifedipine and captopril because it caused rapid hypotension, and it will cause rebound ischemia.
No more use.
What?
Nowadays, no more use.
No more use. It is contraindicated.
Yes, no more. This is the drop of the hypertension has many complications.
Captopril sublingual, nifedipine sublingual, absolute contraindication.
شكرا معلومه جيده عليها.
شكرا انا معك. شكرا. ثانك يو.
Thank you.
الله يعطيك العافيه دكتور صالح.
بارك الله فيكم جميعا.
I think we can now stop the recording and thank you very much for Dr. Saleh. He is, as we said, very good speaker. We are proud of him.
شكرا لك. انا فخور في الجميع جميعا كلكم. بارك الله فيكم. انا واحد منكم، اخوكم الاصغر، واتعلم منكم والله. شكرا لكم.
جزاك الله خير يا دكتور صالح. انت المفروض تعمل لنا محاضرات كيف القاء المحاضرات يا دكتور. الله يرضى عليك ان شاء الله تعالى.
شكرا لكم. تعلمت منكم مساعدتي.
طيب إذا شكرا جزيلا. نختم يا دكتور صالح، بارك الله فيك وجزاك الله ألف خير عنا وعن جميع الحاضرين، وأفاد الله بعلمك ونفعنا جميعا بهذا العلم وأفادنا وأفاد بلدنا إن شاء الله. وإلى لقاء قريب في محاضرة قادمة الشهر هذا أو نهاية الشهر هذا والشهر القادم إن شاء الله.
شكرا ألف شكر دكتور صالح مرة ثانية وثالثة.
شكرا للجميع. شكرا لكم. شكرا جميعا. شكرا. السلام عليكم.
يلا في أمان الله.
في أمان الله.